Bones are great in compression, but they suck in rotation. And the recent Josh Naylor injury is going to help me explain why.
Listen up, everybody. I have some news.
Hey interns, I'm Dr. Chris Raynor and I'm not your everyday ortho. Today I'm going to look at the recent injury suffered by Cleveland's Josh Naylor, and I'm going to use this injury to explain why bones are fantastic in resisting compression forces, but they absolutely suck when it comes to rotation.
Okay.
So how many freaking times do I have to say it? Bones are very strong in compression, great in compression, fantastic in compression, but that they suck. They are crap in rotation. Not even notorious superstars can avoid this fact. Remember what happened to Conor McGregor in UFC 264? But enough on that. Today, our patient is Josh Naylor. While attempting to catch a fly ball in the outfield, Naylor collided with his teammate Ernie Clement and was thrown up into the air. An awkward landing resulted in a deformity of his right lower leg. Ouch. Looks like he's in a lot of pain. His lower extremity looked to be unstable as he moved around on the turf. Eventually, he was stabilized by the medical staff and transported to a hospital in Minnesota for further examination. He later returned to Cleveland to see foot and ankle specialist Dr. Mark Berkowitz. The official diagnosis, a closed ankle fracture dislocation with associated ligament injury, for which he underwent reparative surgery on July 2nd, 2021. That's the information that we were given. But what other information can we figure out with our own critical eye? After some review, I have come up with the following conclusions. 1, the timing of injury. 2, the injury mechanism and the corresponding fracture type. 3, the fracture location. And 4, the type of fixation expected. When Naylor collides with Clement, Naylor is in the process of lifting his right leg off the ground. Clement, on the other hand, is in the process of planting his right leg. As their right legs collide, Clement's momentum launches Naylor's right leg into the air, adding an element of rotation. Combined with Naylor's forward movement, the elevation and rotation caused Naylor to spin around in the air. When he contacted the ground, the toes of his right foot struck first with his center of gravity behind the point of contact. The cleats on his shoes caused his right leg to stop moving while he continued to fall to the ground. Naylor was still rotating at this point while his leg was fixed, forcing his right lower leg into external rotation as he continued to fall backward. Eventually, the fibula could not resist the torque applied by the forced external rotation and it fractured at the level of the ankle. So while the initial impact with Clement looks more spectacular, it is in fact his impact with the ground that caused Naylor's injury. I repeat, forced external rotation of the foot on the leg, or rather the falling body around the fixed foot, is what caused the fracture to occur. The fracture pattern that is typically associated with this injury mechanism is a spiral oblique fracture of the fibula. This is a fracture that travels in a diagonal path down the fibula from one side of the bone to the other in a curved line. It can occur right at the level of the ankle or a short distance above. In severe cases, it will occur with 1 or 2 fractures of the distal end of the tibia on the inside and at the back. In Naylor's case, the fracture occurred as well as a dislocation of the ankle joint. This combination of injuries is called either a bimalleolar or trimalleolar fracture dislocation of the ankle, depending on whether there are 1 or 2 fractures of the distal tibia as well as the fracture of the fibula. It is not clear which one of these that Naylor suffered. Fortunately, however, it was a closed injury without any bone protruding out through the skin, which would have increased the severity level. Generally speaking, there are 3 levels at which a fibular fracture can occur: below, at, or above the joint line. It is uncommon to have the amount of instability demonstrated in Naylor's video with a fracture that occurs below the joint line. This means that his fracture was either at or above the joint line. With a bimalleolar or trimalleolar ankle fracture, both the fibula and the tibia need to be fixed. With a bimalleolar fracture, there are 2 fractures that need to be fixed. A trimalleolar has 3. The standard fixation includes plate and screw fixation on the fibula, which is usually fixed first, which allows us to restore the normal length and rotation of the limb. This is done through a lateral incision directly over the fibula. Through a separate incision on the medial or inside part of the ankle, the medial tibia fracture is fixed. Fixation usually only requires screws. However, if the medial fragment is particularly large or particularly unstable, a plate may be used on this side as well. In the case of a trimalleolar fracture, if it is present, the need for fixation of the posterior fragment depends on the size of the fragment and the amount that it is displaced or moved out of normal position. If the trimalleolar, or fragments at the back of the ankle, are less than 25% of the joint surface and are not displaced more than a few millimeters, this part does not require operative fixation. These cases are reduced into position manually and stabilized by postoperative casting. However, if the fragments at the back of the ankle are bigger than 25% of the joint surface and displaced more than a few millimeters, then fixation is required. We use either screws alone or plate and screws together, depending on the size. Postoperative rehab will include 6 to 8 weeks of cast immobilization and non-weight bearing if all goes according to plan. If healing is going well, some weight bearing in the cast might be allowed around 4 weeks. Full weight bearing will begin once fracture healing has been confirmed. Physiotherapy will start as soon as the cast is removed. Normally, it will be approximately 4 to 5 months before we can expect Naylor to return to training and or practice, but it will likely be around 6 months before we can expect him to return to normal play. So now that we know how and when the fracture occurred, we want to figure out why the fracture occurred in this manner. Why is it that bones are weak in rotation? It all comes down to how bones are designed. Each bone is made up of 2 types of bone: compact cortical bone and spongy cancellous bone. Cortical bone is the shell on the outside, while cancellous bone is on the inside. Cortical bone is arranged somewhat like a bundle of pipes, osteons, that have been tightly tied together by small channels called canaliculi. These pipes, called osteons, are insulated by a layered covering called a matrix. Bone cells called osteocytes live in between the matrix layers. Cancellous bone, on the other hand, is less dense than cortical bone. Think of it like plates of bone, trabeculi, and bars of bone randomly arranged with small irregular cavities that contain bone marrow. Neighboring cavities are connected by the channels. The plates of bone are arranged to provide maximum strength in line with the stress traveling through the bone. When bones fail under compression, axial loading, cracks form in between the pipes and travel down the bone vertically. These vertical cracks continue to form between the pipes without the bone failing for a long time. Eventually, the pipes spread apart enough, and the bone collapses suddenly. This is failure in a single vertical fashion, mode, or plane, the effects having accumulated over time. When bones fail under tension, bending, a la Conor McGregor, cracks form in the alternate horizontal plane along the channels joining the pipes. This type of fracture occurs much more progressively than with compression. Pipes bend gradually over time, with damage occurring more slowly before eventual collapse. Rotation, however, is different than either compression or tension. With rotation, when bones fail, cracks form in between the pipes and following the channels joining the pipes. This means that failure occurs in both the vertical and the horizontal planes, and occurs suddenly, with a significant amount of damage occurring immediately before failure. Because failure involves multiple planes, it is more aggressive and results in the most damage of all fracture types. So that's why bones are very strong in compression, great in compression, fantastic in compression, but that they suck. They are crap in rotation, and are only marginally better when bent. Thanks for watching. I will see you next week. As always, that's been a word from Dr. Chris, not your everyday ortho.
Just a flesh wound.